what I want to do today is, we talked about like the waiving and delegating and some of the elements of informed consent last week. So now I want to just talk a little bit more about the ethical and the legal aspects. And the last section will look particularly as to how it applies to nurses, even though, of course, the consent ultimately allows to be evaluated through the physician. Nurses still have a role to play. Okay. Now, one of the problems with ascertaining consent to a patient is to ask the question, well, how much is enough information? In other words, if the person, because of their autonomy, must make a decision on their treatment based on the information you give them, how much is enough? And, at what point do you say, I think what I said was adequate? There's really no fine, line here. This is a lot of gray area. And you're going to have to, as we'll see here, find ways to sort of assess, like, do you understand what's going on without letting the person think that you're just assuming that they can't comprehend it, right? So these are not malicious, but you're going to have to find ways at least to help, because you will assist the physician, right? How are you going to determine that they understand? There's two ways you could look at this. One way is, remember how I said terms have to be clear? So you could speak very clearly in the terminology, but more likely than not, you're going to be the expert in that particular situation. And just because you're explaining things clearly doesn't mean that they're hearing them clearly. And you don't want, it's not dumbing it down, but you don't want to keep simplifying it to the point where you're no longer being clear. Now, there could be a case where you're not the expert, right? It could be other nurses, there could be physicians that you're treating, lawyers, or just, the health nuts that know every last blessed thing about every nutrition, guide and everything, who will more or less engage you in that. But nonetheless, you're trying to figure out, does this person understand what I'm saying? The other issue isn't that they may not just understand the clarity of the terms, but you're also going to have to try to figure out to determine whether or not they truly understand, or if they're just going along because they don't want you to think they're not intelligent, right? So it could be that they're just following you along, nodding and saying they understand, and you're going to do your best to pick up on facial clues. Is there anything about this that doesn't seem right? Believe it or not, a person's intuition is usually pretty good. If you sense they're not getting it, in other words, you have to find, and this is, I don't care what field you're in, right? I mean, you're likely over the course of your career to become very good at what you do. And you're not always going to be talking peer-to-peer. So you're going to have to be talking in another way. You don't want to sound like you're the individual that knows more than another person. So how do you normally get across your point without offending them? Self-deprecating humor always works, right? So if you're talking to somebody and it appears to you that they're not following you, you can easily just follow up and say, oh, those are just big fancy words, all it really means is this. Or you can say something to the effect, and these are all psychological tricks, right? Something to the effect, I don't often get things either. It's like, I need it simple, so I like to try to reiterate it so that I make sure I'm getting it to you clear. If you can find any trick, then at least you're making certain that they understand whatever it is that's in front of them and what the choices are, so that when they consent, the consent is going to be valid, at least in your eyes, okay? But there's nothing malicious about those per se. They're just things that you need to assess. The other thing, too, and this isn't malicious either, is that not everybody is quite aware of their own health history. Now, it might not be too bad if you're 19 years old and you've only had, allergies or something, but as you get older and these health issues start to stack up, it's real easy to forget, when exactly did I have that done? It might, because time just kind of loses, right? So you might think, oh, well, I think the pain started somewhere, it must have been in June. And next thing you know, they're like, okay, so 3 months. It seems longer than that, and you look confused, right? Now, you're trying to give them your health history, and this health history is going to have some some bearing on how they are going to start treating you, and that treatment that you're consenting to is going to be based on how you speak to them, or they speak to you if you're in the nursing position. So does anybody have grandparents or parents or anybody that keeps a health notebook? Somebody last period did. My mother did, right? By the time you get in your 80s and you've been having certain procedures done since you were in your mid to late 30s, there's no way you can remember all those things, including how many medications. So maybe even now you might be on a few different medications. Do you go into the doctor and they start rattling it off? Are you still on this? What is that called? You know, because they might be giving it to you in the actual name and you're hearing the brand name, right? Or you're not quite sure on the dosage. Or no, I don't take that anymore. It's like, why is that on the chart? I mean, every time I go, there's something there. It's like, where did that come from? I wasn't on that for 4 years now, and I'm only on it for 2 weeks. So why is it on my chart? You know, and you get concerned about this. So my mother would have one of those little marble composition books, and she would just write everything down as these things were happening. So this thing was old. But when she came to live with us in the last, like, 6, 7 months of her life, and I had to get her a physician that had, you know, attending privileges at the hospital so that we can get some treatment for her, when the nurse said, well, let's just work over your health history, we just handed the notebook over. And she smiled and said, oh, thank you. You don't know how this helps. But that's part of it, right? So it's not just understanding, is it clear, or feigning understanding because you don't feel intelligent. It's also, is the person going to be able to give you their health history in a way that's, well, let's just say this way. You have to find a way to get the health history out of them, oftentimes when they're uncertain. The level of dosage, how long I've been taking it, you name it. But again, there's nothing malicious about any of these things. Now, I think the text actually listed 5 constraints on consent. I'm kind of like lumping a few of them together because I don't often see these as mutually exclusive, right? So I don't see any reason for us to try to delineate the difference between coercion and manipulation. But nonetheless. Okay, so PE up there is patient education. There's a couple ways you can look at that. One is that how far do you go about educating them so they fully understand what's in front of them? And are you going to be selective in what you give them so that your thinking is just going to make it clear what their choices might be? So I always lean on the side that you give them more information, even if it sounds confusing, because it's my ethical background. So let me give you an entirely non-medical scenario. So my wife, you know, who runs the business and we ship stuff. When my brother was running the website for a while, when I took it over, the first thing we did is get rid of free shipping. Free shipping, everybody knows it's not free, right? We already know that. But free shipping has to be calculated based on the highest average cost, which means that, you know, if I'm shipping to somebody that's in Pittsburgh, since I don't know where this person's going to be from, I have to assume that they're going to be the farthest known distance, which means that the product cost is going to go up. If I just charge the product cost plus shipping, the actual shipping, then the person in Pittsburgh is going to have less than the person in LA. And to me, that's fair. But people don't often like that. You know, so when I was talking to a businessman, he kept saying, stop trying to educate your customers. They like free shipping. I said, but it's not in their best interest. It's in their best interest just to pay for the product and then shipping, whatever it is. I mean, they can see it through FedEx. I don't make anything off of it, that type of thing. But I get it. It does harm it. It does harm the relationship you have. How far do you go trying to educate, in this particular case, the customers to let them know that this is in your best interest? So how far are you going to go with patient education to let them know that what you're trying to help them with, as far as the knowledge and information for consent, is in their best interest? That's part of it. Will you use any of that information in any sort of manipulative role, right? So by being a little more selective, perhaps you can nudge them in one way or another. So that may seem like it's, you know, innocent and benign, but in some way does undermine their consent because they don't have all the information. This is an art, and there's a gray area, right? And the white lab, you know, effect. I think it was in the text or some other case study I was reading where it was a doctor's technique. In other words, I really would like them to do this. So here's what you do. Ask them to come into your office for a consult. Make sure you have your lab coat on, the stethoscope around your neck, and sit at your desk. And it looks a little intimidating. When the person sits down, they're thinking, you know, I better go with what this person says. You know, that may be all well and good. Maybe what you're doing is perfectly fine for them. But it could, in a very subtle way, undermine their effect. Okay, so you know, I'm at a doctor's office, it's a cardiologist, right? Hey, your blood pressure looks a little high, so it's 135 over 78. I'm a wreck, and I just had 3 cups of coffee. I mean, are we gonna make a call here? So you're saying you don't wanna try any medication? Yeah, I'm as clear as possible, I'm not trying any medication. Okay, because just to be clear, I'm a cardiologist, right? You know, what did you just hear? You know, am I not competent enough to make my decision on that type of thing? You know, now that sounds like it's all like benign and such, but it's intimidating. If you had a person that, you know, wasn't as assertive, you would go with it, right? So this whole idea that you want to give them as much information as possible, you're going to have to figure out what is enough, but make sure that you're not trying to manipulate them in some way, even if it's for their own good, right? That's part of the issue that we have here. Offers, rewards, undue influence. Now, it could be that we're talking about some particular study. I think that's how the text laid it out. So is there an incentive there? It could be financial, right? And such. And we're not even getting into all the socioeconomic, racial, and ethnic issues that could be involved here, right? I mean, there could be those levels of intimidation that get involved in the whole thing. So dangling a gain. It could be something as nefarious as the person saying, well, I'm not going to treat you. You know, look, this is, and I think I shared with you the one story that my sister-in-law, when she had a ruptured spleen, yet undiagnosed, the physician literally, the surgeon literally said to my wife's family, hey, you want me to cut her open? I cut her open. I mean, okay, now maybe back in the 80s, this was a different, you know, scenario, but still, that would certainly be them trying to manipulate the consent, okay? Or again, and this is why I didn't see much difference between this and the nudging and like code effect, and just withholding information. Now we're going to do a real, just like a, not a text to poll, we'll do that later, but we're going to do just a one-page case study here where you can see perhaps the doctor was withholding information, particularly because they wanted this to be done, right? So it's a concern. And okay, anybody here watch Law and Order? What's that? You do. You do. You wouldn't say that. So my wife, you know, she gets tired of it, right? But a lot of the issues that, you know, not the issues we're going to talk about today, but a lot of the issues that show up in medical malpractice and such, you know, they wind up in their narratives, but they're all true stories. Like if you saw the one that had to do with frozen embryos and the mother died, and where do they go into the will? Do they go to the husband, the wife, I mean, all of the estate? So these are all, I mean, whatever you see on there, even if it seems a little outlandish and they made it dramatic, it was probably based on something that came out of a newspaper article. Because I often watch these and I'm like, I remember reading about that. I remember reading about that. That type of thing, right? The other one is medical paternalism, right? So this is the problem. Now, we know that that's not good. We want people to make decisions for themselves. But did you notice how we're really trying to balance two goods here? And this is the problem. So one of the issues that when you study ethics or do ethics is that very rarely are we making a determination between a good and an evil. It's always between two goods. And how do we balance those? It's not easy. You know, so here we're basically trying to balance, you know, how to not allow this person to do harm and how to get a benefit out of it. So really we're trying to balance beneficence and autonomy. In other words, we really know what's good for the person, but we got to let them choose that. Yes?
I just have a question on something we kind of talked about last week with like, so you just said like you want the person to be able to make a decision for themselves. And like, why would someone want a proxy? Or like, why would someone want to like not make the decision and want someone else to do it?
Okay, well, you know, do you know anybody, I mean, not you or anybody, do you know anybody who like doesn't question things when they go to the doctor? Do you know anybody like that? My father-in-law was like that, God rest his soul. You know, my mother-in-law had to go with him. So if he would go by himself, he'd come home with like a new prescription, and my mother-in-law would say, what's that for? I don't know. Ask the doctor, he's the one who gave it to me. You don't even know what this is. Why should, look, he's the one with all the education, you know, that type of thing. So, you know, now that's not proxy per se, but that's not paternalism either, because you're willfully putting your trust into the person. The proxy would be is if there's a language barrier, or if the person was older. Like I was with my mother, I trust you.
It's if like, so if they had some sort of like don't wanna say like incompetence, but if they weren't like fully able to, like, if I could understand everything that was going on, I would be able to make it for myself, I wouldn't need a proxy.
Correct, yes, no.
Okay.
As a matter of fact, that would probably be a complication.
Okay.
Like, why is it that, you're getting this person involved? They probably would think they have something over you, that type of thing, right? Okay, so if anybody has children, or when you get older and you have children, this is the struggle that you always fall into with your own children. You want them to make their decisions. But you also, because you're older, maybe wiser, but at the very least you can see farther down the road. So this is not a good choice. I mean, it's not that it might not work out for you, but this is likely what's going to happen. So how far do you go with allowing them to make those choices because you respect them as individuals, persons, and they deserve autonomy, and how much of it do you want to guide them? And I think I shared with you, this is what my wife taught me with my daughters, is that, you raise them, now you gotta trust them. Okay, so, your relationship with the patient isn't quite like that, but your relationship with the patient is, we're doing our best to inform them, and as long as we feel we have, at least a moral certainty, adequately inform them, we're gonna have to go with their autonomy and trust it, right? And a lot of this, maybe, my wife's big for talking about the pendulum swinging. Maybe it's swinging a little bit too far towards autonomy. If you read the literature, you hear a lot of arguments about that, particularly in other countries. We might be a little bit more liberal toward the autonomy in the United States, maybe not so in some other countries. But the reason why it's swinging towards autonomy is because it came from paternalism, where the physician, maybe if somebody, watch an older movie on Turner Classic Movies sometime. You like that? I love Turner Classic Movies. And every so often I see one where it's at a physician's house and the individual was not told that they had 3 weeks to live because they probably wouldn't be able to deal with it very well. They just tell the family, nobody wants to tell Uncle Joe that you only have X. That type of idea was more standard. So the physician was not acting godlike, but in a way, at least analogously. And we're trying to get away from that. So that let the person know that they can make their own proper decisions, right? So this is the gray area that we're trying to get through beneficence and autonomy. So I have a case study I want to do on this, and then if you have any questions, we can talk about it. And I want you to tell me what you would do here. So you have your nurse who's cared for this newborn baby with severe heart defects, and the parents had to decide whether or not the baby would have surgery. And they have no previously knowledge of the considered condition, nor do they know about its seriousness, so they just trust their healthcare providers to help them make this agonizing decision whether or not to operate. Well, the cardiac surgeon presents surgery as representing the difference between life and death. You don't do this, the child can die. And makes it as the only option. No mention of alternatives. No wait and see, heart transplant. It's frustrating for the nurse because they know the parents were not told the likely long-term outcome that's going to be. It's going to be a lifetime of acute and chronic illness, perhaps, right? The rationale was that the limited information is best, and parents are really, they can't understand the anatomy of a normal heart, let alone some sort of heart that has abnormalities. So the nurse suffered moral distress here as she considered that the surgeon described a falsely optimistic view of life after the surgery and doesn't think the parents received all the information they needed to make the best decision for their baby and their family. What would you do? Okay.
I will confront the physician.
Okay. Yeah, maybe that'd be the best first thing. Of course, you might have a relationship with them, so maybe, let's pretend that you don't, you certainly want to do that. Maybe you would either way.
It's like not the nurse's duty to explain everything, but it's like the nurse's duty to, at the end of the day, to be the advocate for the patient.
Well, actually, we're going to see that you do have a certain level of duty to help.
To like, make sure they know
Yes.
everything, but not to get the information.
But, and what you're right, but see, we're going to see towards the end here, you're going to have at least a legal obligation, probably to witness the signature. So at that point, we're getting ahead of ourselves, but at that point would be a really good time to bring up, have all the options been told you, This is one of these situations where you're going to have to get the lay of the land. And you've done that, in high school, in here, I don't care where you go to work, you get the dynamics for your group. And you get a feel for what goes on, who you're working with, and what their personalities are, and you have to rely on your intuition and really try to hone it and make it keen. So in this particular situation, you might know right off the bat, look, first step, I will say something to the doctor. Look, I'm concerned you even say anything to them, and I don't think it's ethical, and I do think I need to say something. Would you like to go back and talk to them? You'll have to play this out. Chances are that it could get you a little bit of hot water with a particular physician, but nonetheless, I know me, I probably would find a way to get this out. It's me. But you're probably right, talking to the surgeon first would be the way to do it. Just depends on the dynamics, okay? But nonetheless, you see, he's not malevolent. Let's not pretend that this surgeon thinks they're doing something bad. They probably are comfortable with this. We don't have to be so cynical to think that they have some sort of incentive, that we do X amount of surgeries, we get this. We could just say that they really think this is the best for them. And they're thinking, how am I going to explain all this? We're not up against time per se, but still we don't have forever. And at what point do I say they know enough? In other words, he might try or she might make the case as a surgeon saying that how far do I go with the patient education? I can't put them through, the equivalent of a bachelor's degree to make them understand the issues of this child's heart. I don't think you need that much though, right? People make the decisions quite a bit. Non-related, but I always like to share good news. Anybody reading the paper about a school teacher who donated her kidney to her children's father? Anybody see that? It's kind of sweet. She was an elementary school teacher, and 3 of the kids that she taught, her children, where she found out the father was at the point where his kidneys have failed. He was home for a transplant, or immediately, obviously, hooked up to dialysis. And she went and got herself tested and found out she was a match, and said she would give her kidney. And the father, I was listening to him on the radio this morning, he was broken up, because he said, I can't believe somebody would do this, right? Putting himself through that. And the woman said it was all worth her while when the 3rd grader that she taught came up to her and gave her big hugs and thanks for saving Dad. So it was all worth it like that. So it has nothing to do with anything here. I love sharing good news when it comes out because we don't often hear that, do we? Anyway, so the whole point to all of this with how much is necessary is that, more is better. And as long as an individual has time, as a nurse and such, to spend with your patient, even though it primarily is with the physician, you realize that, more is better. And we don't, but I guess you could get somebody confused too. And perhaps you could even talk about that being a way to manipulate somebody. Give them some information and they just throw their hands up and say, you do it. I didn't think about that, but that'd be another way. Right? Any questions on this? It's kind of straightforward. Now, when we talk about legal issues, and this is going to be really on the physician's shoulders. This is just FYI for us here in the program. The irony is a standard is something we could all rely on, but here we have no real standard. Here's part of the problem, and we'll look at the physician and also the patient standards. It was a non-medical situation that I could have been involved in a court session where I knew the ethics of it. And when I met with the lawyer and decided not to pursue it, the lawyer said, there's no way you're going to lose the rational argument from the ethical standpoint. He said, it's likely that you might win the legal argument, but here's your concern. The experts, you're an expert, there's no experts on the jury. So no matter how well you display, the scenario, and no matter how well you lay out the evaluation, it comes down to whether or not they see it that way, that type of thing, right? So when you, again, think of, law, legal cases here, you're up against that, right? Legal cases will determine how the hospital protocol gets switched around. I see it with my wife at the nursing home that she's, the skilled nursing that she's works at. Things have changed over the last 15 years, and they're going to change the entire course of your career. The ethics don't necessarily change, but you always have to comply with the legal standard that at least you can assume might be used in a particular case. And if HR departments do nothing, HR departments are all about reducing liability, so they want to make sure that you're clear. So there's two physician standards, and think of it in terms of from their position. And this first one is the physician's community standard. So it's not some hypothetical, it's not what this individual physician would do. So think of an expert witness showing up and trying to argue this. So forget about the expert witness. Think about a lawyer showing up and trying to argue a malpractice case and making the claim that this is what a community of physicians would typically agree upon as protocol, okay? So what's good about this is when it is used as a legal standard is that it does, at the very least, show some consistency, right? It's not going to vary case by case by case. We don't quite know if it's going to be an adequate standard. In other words, whatever the physician's community standard is might not be enough for what is done in the exact hospital. Might keep out of legal hot water, but nonetheless, it may not be something that is adequate enough for you to do your job in a great, let's just say in an excellent way. They also might argue that there's a physician reasonable standard. So in other words, this is more hypothetical. What would any physician who's reasonable do in this particular situation? You'll probably see this standard come to the fore for when they're trying to argue something that's a little out of the hat, you know. How does this apply? Because you can apply this one probably a little easier to a particular case, okay? But we're losing part of it as being a standard, unfortunately. Let's see. I want to make sure there isn't something particular. I didn't want to spend too much time with these. I thought your book did a decent job on it. Okay, let's see. Yeah, I guess the only thing I wanted to add about the reasonable physician standard is that's the one that you probably would see employed if it was an expert witness show up, and they would make the claim that here's what should be done. If we're going to look at it from the patient's perspective, rather than saying what would be a customary thing for the physician to do as protocol, here we're saying what would be the reasonable desire that a patient would have in this particular treatment. So again, you're trying to at least have a consistency by talking about a greater pool that helps you set that standard, but still, this one would really come down to, and it's not so much of a standard at all, it comes down to what did that particular patient desire. So this, if a patient had higher than normal expectations and they weren't satisfied with their care and then they tried to sue based on the fact that they expected X, Y, and Z and they were only given X, they would probably try to make an argument from the subjective patient standard, but you can almost rest assured that the expert witness will show up and argue from the reasonable physician standard. And now you have these two things. So the whole point of this isn't so that we're trying to be so clear as to what gets applied here, just to let you know that, you know, again, one of the issues with the legality of what happens in a particular profession is how do the courts find? And I've already shared with you in a previous class that my friend who was an elementary school principal, when he went away to their training or whatever, he said when the lawyers came in, they were very clear to let them know that the standard of what will be considered legal is dependent on the judge. You know, and so it changes from case to case. Maybe not totally flippantly, but nonetheless. Now, there are exceptions. I mean, the only thing that your book said beyond that was that you can blend some of these, but I just left them go, right? So there really are three exceptions. The first exception would be if you can ascertain some incompetency in the particular patient. The incompetency could be that they didn't quite understand it. The incompetency could be that they didn't have the wherewithal to understand it, that you underestimated, or you overestimated their ability to comprehend what you were telling them. Maybe they never quite grasped the adequate seriousness of what was going on. It's like, you know, I remember when my mother, we had to make a decision on a particular operation. She didn't have it. She'd have basically 3 weeks to live. And she seemed agreeable. She was like, well, thank you. It was a team of doctors. And she goes, I appreciate you sharing it with me. And now, I had procs, and after they left, I said, how do you feel about that, Mom? Oh, it's okay. I said, well, when you say it's okay, what's okay? Is it okay because, maybe we all go through this, or did you understand? I mean, I wasn't, the response didn't quite seem adequate to what she was hearing, In the end, though, I think she did understand it. But it took me a while to figure, and after the doctors left, I'm thinking, they left it with me, but I'm thinking, I don't know what you would have done if I wasn't there. I'm not quite sure how I would have figured all this out. Maybe you could have talked to her more, but nonetheless, right? So anyway, that's part of the incompetency. It has nothing to do with the person's intelligence level whatsoever, right? But in other words, maybe even if that scenario with the child needs the heart transplant or surgery, maybe that would be part of it. Do you understand what's ahead of you? Like, let's say they really chose that. Do you understand, like, the lifelong issues that might concur because of what, or occur because of your choices? So that's one of the exceptions, that if there's some sort of incompetency involved. The other exception, well, there's two more, but the other exception is emergency. Okay, now an emergency doesn't get rid of consent per se, but it's going to be implicit unless you hear otherwise, right? So we go back to the scenario we did in class last week with the motorcycle driver who had head trauma. We weren't sure if they were in shock or whatever. Even with the notes and everything else, even if it were signed, none of that matters. Like, this is an emergency situation. The person needs to be intubated, and we can't ascertain whether or not they're competent. So the emergency overrides that per se. All right. Now, if there were a proxy involved, or if they were younger than 18 and there were parents involved, then that would not suffice. But nonetheless, it at least does in that. This third one, I want to mention, and I think the book mentions it. If not, this has been in plenty of case studies, and it's in plenty of literature. Therapeutic privilege is when the physician has determined to some degree that the information I'm about to give you is going to be so traumatic that it's going to actually upset your ability to give me valid consent. Now, I'll explain what that means, but first let me say that the AMA has determined that this is unethical. And I think like through 2006, all right? Let me give you a scenario where I think it can be applied in a very limited way, and then we can go from there. So let's say that you had a person who you knew was so despondent and so severely clinically depressed, and you are just, as a physician, going to give them news that's going to just throw them over. In other words, you're so concerned with you delivering what you have to say that you'd be fearful this person would leave this building and do something almost immediately. You can withhold that, but only, I would say ethically, only for a short time. In other words, you can withhold that only to the point where you can get somebody else in this group, right? So I'm imagining somebody would say, look, we need to talk to you before we discharge you here, okay? There's some things some serious things I want to talk to you about, but we'll get to that. You give a ride. Is there somebody that you can come here and be with you? Because you don't want to just say, is there somebody that I can call to be here with you and to talk? At that point, you're like, what do I got? A day? So if you can make arrangements so this person's that, in other words, you're not withholding the information except to the point where you know that it can be delivered in a means that's going to put them in a safe environment. So in the past, it was always a little controversial, at least in the last few decades, but would a doctor withhold it, thinking that what I'm going to say is so traumatic to the point where perhaps that would just psychologically throw them over the edge, and they can no longer make a good, valid decision. We lean towards patient advocacy, right, and towards information. So, nonetheless, so when I put it up there as an exception, I'm only saying that it is an alternative, but it's not an ethical one, unless we're talking about a very, very quick scenario. I can share with you one time when I was in my 20s, I did a lot of physical work, and I had wear and tear injuries, and I had to go in there so often. And I'm in this, just a room at the GP, and somebody's whacking. It's like somebody's throwing themselves up against the wall here, to the point where the pictures on the wall were like going sideways and stuff. And I'm sitting there laughing, thinking, what in God's name is going on over here? And all of a sudden the doctor comes in and then he's like, I'll be over here in a minute. I'm like, you don't need to, just go do what you need to do. Well, the person, and the doctor, what I liked about this doctor is he worked on an Indian reservation for almost his entire practice, which means that he was very informal. And sometimes that's good, right? I mean, he treated everybody as equal individuals, but he was more informal, and he would have been a great person to talk to about how to deliver some information. So anyway, this guy, first of all, was drunk, as much as you can imagine. Why is he there? Because he has a defibrillator embedded, and he's already has set off like 5 times that afternoon. I mean, so the doctor comes in and says, he's drunk, and he died 5 times already. This is how he's talking to me, right? Okay, so if there's something that needs to be spoken of to the patient, this is not the environment, right? I mean, so there, I guess technically you would call that therapeutic privilege, but it's just a matter of you need a different environment. Somebody's got to come here. We need somebody else. This person cannot walk out of this room like they are now, that type of thing, okay? Nonetheless. So there's, some exceptions. Okay, so as far as nurses then, we know that consent and the liability for consent, it was with the physician. But nurses, thank goodness, are so collaborative anymore. I don't think we have the model we had from years ago where they were like, go get it type people. I think the doctors are going to obviously rely quite a bit on the nursing staff to help them. That's what I'm going to explain. Help them with assess and all those types of things. And DNA codes there deal with this particularly. All right. So let's, and I put these in different way, I think, than the book had it. So this would not be, except for maybe the witness, I don't think you're going to have the legal issues here, but you are going to help the physician assess the level of competency and the level of consent that this individual is giving. And I know, like with my wife, we had 3 daughters, and the last one was born through a midwife, but through all, which was her best experience. She wished she would have done it at the beginning. But the best experience that she had through all those instances were the nurses, because they were the ones in the room almost the entire time. And the doctors know that, right? The doctors are like only flybys half the time. So, when it comes time for the doctor trying to assess a particular patient's competency and such, they're going to rely on the nurse. How do you see this, right? So it's a matter of you helping assess, but also assisting the physician. It's ultimately his or her decision. But if they're wise, they're not going to make it on their own. Now, the reality is that we all know that individuals, not everybody is really nice. There's only way to say it. Some people are jerks, right? I don't care what field you're in. And, I've been in front of enough physicians where, like, in other words, if a physician is writing on a clipboard with their back turned to me, barking off words, I stop talking. And I don't do it to be a smart aleck. I just stop talking. And then they turn around like, did you hear me? I said, I did. Would you mind just turn around for a minute? I don't hear you that well to begin with, and I would like to at least talk to you. If we're in that big of a rush. So, it's not going to take you long probably to get cynical in your field. I can share with you how it happened with my wife. But with the Affordable Care Act, they're under the gun. So, 15 minutes in and out. Perhaps if it's like an upper level thing, like you're visiting a neurologist, it's 30 minutes in and out. My wife, when she was at her neurologist, the lady was getting consistent text from the desk. And now, this lady was older, and she was there a long time, so she had a lot of political clout. She put her phone down. She goes, all they're trying to do is tell me to get out of here because they have to get the next person in here because not they have to code it a different way, right? So, I think, the nurses at the very least, they're the point of contact with the patient. And it's hard not to be apprehensive and such when you're in a situation you're trying to get care, and you're not quite certain what the information is that you're getting. Am I getting all the information? Should I ask more questions? Am I asking too many questions? Am I looking at the contract? I mean, so, you get good at reading that stuff, but if you can always think in terms of, this is me sitting there, this is why your concept of personhood is so important, right? And the dignity of the individual. If it's me sitting there, how I want to hear it. And that gets to be a little tiresome, right? It's like being in any type of relationship, if you try to do it really well, it gets tiring over time. But nonetheless, it makes everybody's experience quite a bit better. That being said, there are still legal issues that you could be involved with when it comes to consent. You don't, okay, like if somebody needs an insulin shot, you go in and give an insulin shot. If somebody's taking somebody's blood pressure, you're taking their blood pressure. You need consent for those. But their lack of opposition is your consent, right? So you don't just go over and do things, in other words, you would not go and give somebody, an insulin injection into the floor of their stomach without saying something to them, right? So you just say, I need to give you your insulin shot, and then if nothing is opposed, then the consent is implied. Of course, if the patient saying, what are you doing? No, you're not. Well, then you stop, right? So that could be a legal issue. It's implied as long as they don't oppose. Same thing with taking a blood pressure. I'm just going to take your blood pressure, your temperature. They don't say anything, you move about, right? Maybe a little bit more formal if you need to do something the next notch up, like insert a catheter or something like that. You'd want to at least let them know this is what I'm going to do. And if it were me, I'd like to hear this is why we're doing it. And it's likely we'll be in, I don't know exactly how long it'll be in, but we'll have it in for at least this amount of time. That type of thing. So those are issues of consent that are still there, and they're still legal and binding to you, but they're not as formal. Like, oh, I'm sorry, I didn't do these last two. I totally forgot. The witness is the nurse is typically going to be the one that has the actual document. So you're going to sit down and say, okay, here's the procedure we're going to do. I need you to sign this consent form before we can move forward on this. All right. At this point, too, you're going to do probably a lot of clarity. If they have any questions, you're the one that's there doing it. So if you go back to that case study where if you were the individual that had to go over and get the parents' consent for them to do the surgery, this would be your opportunity to do something if you didn't already speak with the doctor. Say, look, we're doing this consent. Make sure you understand all the alternatives. What alternatives? Well, there were options. Perhaps they need to be explained to you, that type of thing. Again, it could get you in maybe political hot water, but that's part of your role. So the legal thing there, at least be witness, but still assist, clarify. And again, you're the one you're the boots on the ground, so you're the one that's going to be spending the most time. The last thing is you can be legally liable if, for whatever reason, you have realized that the patient has not been properly informed. Okay? So we have to really work out a bigger scenario with that other case study as to whether or not you have not just, I think you at least have an ethical obligation and a legal obligation for you to bring something up or to at least pursue it to the next level, which may be you talking to the physician and your supervisor may be sufficient. It isn't your call. But you do have some responsibility to make sure that the person understands it. On the other flip of this is that if you realize the procedure was done and that consent was not properly given, that too is something that you legally have to report. You can't let that slide, okay? So, questions? Let's do a text-to-poll case study then. It's still Stephen Bueno 595 at 22333. Okay, so Jimmy, these are real case studies, by the way. The names have been changed, and I didn't change the names. I kind of think I'd come up with better names than these, but nonetheless. Did anybody ever see One Flew Over the Cuckoo's Nest? Nobody? You did? Oh, you got to watch it. Okay. Then my jokes won't work. Okay. Nurse Ratched was in there. Anyway, Jimmy Chelton, 27-year-old male, suffered bipolar disorder for 9 years. He's suicidal, attempted to kill himself by swallowing a bottle of aspirins. and since then he was involuntarily admitted to a mental illness unit in the hospital. Now, Jimmy's hostile, verbal, including obscenities, racial and sexual remarks, and threats that he would stab people as soon as he got the chance. Although a few of the staff members in the unit got along well with Jimmy, his insulting behavior managed to upset even seasoned psychiatric nurses. Anybody here thinking of going into psychiatric nursing? Oh, you are? Your mother is? Oh, good. My daughter would like to do that. Okay, so Jimmy was receiving medication to keep him from having mood swings, and he consented to those. But the medication did not calm his improper comportment towards many of the staff members. So Nurse Canterbury, a psychiatric nurse for 12 years. So when you're trying to think of like, by the way, this one isn't as simple as the ones I'm going to try to give you on the exam. I'm trying to keep those where there's not so much gray area, because I just want to assess that you understand how it's going on, not to work out all the little nuances. But this would be something you think about right here. The minute you see this psychiatric nurse has been there for 12 years, this is a seasoned nurse, all right? This isn't somebody who just started. Okay, she believed that Jimmy posed a real threat to the staff. She contacted a hospital bioethicist, Dr. Elizabeth Cheshire, because she believed Jimmy should be chemically restrained for safety reasons, but thought the others on the team failed to understand his potential for violence. So hold on a sec.